course on what after residency. During this course, we'll be covering a wide range of topics, including international examinations, fellowship options, the ICO fellowships, and also touch very briefly upon, life, in a sense, out of clinical ophthalmology and more or less as an entrepreneur. Welcome, Dr. Gandhi. So, I think without further ado, then I'll jump into my first presentation. So I'm Dr. Devendra Venkatramani, and I'm very happy to be joined today by distinguished faculty and doctors from around the world. And the first talk for this session is on the FRCS examinations, and we'll just dive straight into that. So the Royal Colleges are quite a few actually, but I think for most ophthalmologists, these are the three important ones. That is the Royal College of Surgeons of Edinburgh, the Royal College of Physicians and Surgeons of Glasgow, and the Royal College of Ophthalmologists. For this talk, I'll be focusing on the first two, essentially the Royal College in Glasgow. And you can see over here the dates of, the dates that the charter was drawn up. So they're really very old colleges with a lot of ancient history that comes along with them. It was established in 1599, and these are some of the images from Glasgow when I had gone there for my convocation after successfully clearing all parts. And just as a side note, that's a fried Mars bar. Glasgow is famous for its deep fried foods, and no wonder it's the heart attack capital of Europe. So these are some of the images of the convocation ceremony. I'd gone there with my dear friend, Dr. Asif Virani, who had given the exam along with me. And, just to stress the importance of someone you can study with and someone who can, help you through that process. It's always useful to have a study buddy for this examination. It's a very glittering ceremony with a lot of pomp, so you can always look forward to enjoying that once you've gone through this arduous process. So the examination itself is divided into three parts. The first part is a MCQ examination, MCQ test with 160 questions, and it's done for 2 hours. And you have almost equal division between these topics of anatomy, physiology, pathology, and optics is also a part of this examination. Part 2 has been changed from very recently, so it's not how I gave the examination, but now Part 2 is a single examination. That's an MCQ test. 180 questions and 2.5 hours to solve them in. And the broad topic is ophthalmic medicine and surgery and general medicine, the management of acute medical emergencies and neurology with particular reference to ophthalmology. And this is the breakup of how the weightage of questions will be. And just to draw your attention to the fact that general medicine and medical emergencies accounts for 8% and 3% of the questions respectively. So this has replaced the theory or essay writing component of Part 2. So now Part 2 is a single examination. There are no multiple parts or sub-parts of Part 2. Part 3 has remained the way it was. It comprises of 2 parts, the structured oral examination, which is also called the OSCEs, and there are 3 table vivas that are conducted in this examination. The first station is lids, oculoplastics, and anterior segment. The second is posterior segment, which also includes glaucoma. And the third is neurology, motility, and general medicine. And then you subsequently, on another day, appear for the clinical examination, which has 4 stations. And the 4 stations are anterior segment, posterior segment, neuro-ophthalmic and ocular motility disorders, and oculoplastic and lid disorders. So unlike Indian examinations where we could afford to leave for option various topics in neuro-ophthalmology and oculoplasty, you cannot really do that in this examination because you have to pass in each of these stations to clear the examination. Now there is an option of getting a degree called the MRCS Ophthalmology from Glasgow, which is available if you have completed the Part 2. Essentially, after Part 1 and Part 2, you can avail of this degree, which is the MRCS. So who's eligible? So for part 1, you need a minimum of 2 years post-qualification experience, including your internship of 1 year. For part 2, it has to be 6 years, which includes your 1-year internship, and 4.5 years of that post-qualification training has to be in ophthalmology. So you may have done a post, or you may have done some few months in a different specialty. That's okay. You can show that certification as part of your eligibility. And essentially, part 3 can be applied for if you've completed both part 1 and 2. Now, these fees are a little outdated. The simple reason is that since COVID, there have been a lot of changes in the fee structures. So this is essentially about a year and a half old. But you can see that it already runs up into lakhs of rupees if you do the conversion. So it is something that one has to be really mentally prepared for, because there's no point in entering the stream and then finding it to be too expensive to complete. So have that thing in mind before starting. At the same time, bear in mind that there's a 5% to 10% increase every year. So by the time you give the part 3, which may be 3 or 4 years down the line, the fees would be quite different than this. So it is really something to spend a lot of time to think about. Again, the website says that there's a maximum of 6 attempts for each part, and of course you have to pay the full fee for each attempt. So I don't think anybody's going to attempt the examination a 6th time. You'll be quite old and infirm by the time you reach that. So try not to think too much about the attempts and try to clear it in the first shot. All of these and other details will be available to you on this website, which is the official website of the Royal College. So you can really go into all the nitty-gritty over there. And of course, apply online for the examination. Now, the Edinburgh College had this sort of flirtatious relationship with the ICO. For some almost 3 years, they, in a sense, outsourced their examinations to the ICO and stopped conducting the examinations themselves. But now they've separated, and since June 2021, now they're restarting, I should say, their examinations for the MRCS and FRCS. However, if you have completed ICO examinations between these dates, you will be eligible for the appropriate, recognition from the Royal College of Surgeons of Edinburgh. So unfortunately, the website, which is rcsed.ac.uk, does not yet talk about the examination fees, examination dates. I think all of these are still to be confirmed and to be decided. So we'll have to wait patiently for them for further clarity on that. So in general, the examination technique is something called the modified Angoff technique, where you are not really, there's no pass mark. Whereas in Indian exams, you have a 50% score allows you to pass the examination. Here it's not that. Here the pass mark is variable, fluctuates depending upon the difficulty level of the examination, which is assessed by the examiners or the paper setters. So you may, you have to clear whatever the pass mark is. In a sense, the pass mark is higher if the examination is deemed easy, and it's low if the examination is deemed to be difficult. So how do you really prepare for this and in general other examinations? For the optics section, I would strongly recommend reading the textbooks by Elkington and Dr. A.K. Khurana's textbook of optics and refraction, really quite comprehensive and very well laid out. For basic sciences, indispensable is the MCQ book by John Ferris, which also gives you explanations for why a particular answer is correct and why the other answers are wrong. And if you really want to go into depth, there is of course, the tome, which is the textbook by John Forrester, who incidentally was awarded the honorary FRCS at the same convocation that I happened to attend. For the part 2, whatever your postgraduate syllabus is, the MS or DNB syllabus is definitely adequate, but you may want to brush up on the MCQ aspect of it by using this book by Jeffrey Lampkin and other authors, the Massachusetts Eye and Ear Infirmary Review Manual. And this is the ideal book for reading up on emergency medicines. That's the Oxford Handbook of Clinical Medicines. There's a segment at the end which talks only about clinical emergencies and how to deal with them, and there's a lovely flow chart approach to each of these emergencies, so it will help you when you appear for the MCQs in part 2. So a few tips. One is that, this examination is extremely practical. They're not going to ask you percentages of incidence of a particular disease or some esoteric theoretical point, but you need to really have a very methodical approach, especially in the third part when you're face-to-face with a viva, with an examiner, and sort of move from a life-threatening disorder first to a vision-threatening disorder to a cosmetic disorder. And with regard to the clinical examination and viva, they're really something that we are not trained for. The viva, which is the OSCEs, is really a very rapid fire sort of examination, and you have these stations of 20 minutes with 2 examiners, that's 10 minutes per examiner, and they have a set pattern of questions. That is, it's a structured examination. They have specific questions that they can ask you, and the model answer has certain keywords which you need to hit in order to score, and they won't proceed unless you are able to, either say that you don't know the answer or you answer it adequately. So many times the questions are in the form of a picture or a clinical situation, and it builds on the previous, so the subsequent question sort of builds on the previous one. In the clinical examination, where you're actually examining patients, you have all of these, stations, as I discussed earlier, but you have a very little time at each station. You have only about 12 minutes at each station and 2 examiners, and the more number of patients you can see or you can go through, the better. So I'll just say that, you need to practice this because it's not a skill that comes very naturally. And why does really anybody do FRCS examinations is because it does offer some tangible benefits in that you don't have to do the PLAB if you want to, look for a job in the UK. You can directly register with the GMC. There are obviously, better remuneration in certain countries and in certain institutions if you have these degrees. You can, if you're interested in the ICO examination, you have cross exemptions, and many people just like to see a lot of letters after their name. So whatever your motivation, I think it's a great examination to give. However, it has a few disadvantages. It's really not a licensing examination. Just on virtue of this examination, you're not qualified or licensed to practice anywhere, and they are very expensive. So think about it before you really jump in. So at Lakshmi Eye Institute, we have this FRCS refresher course that we've suspended for the last 2 years, but we hope to restart this year. This would be our 5th time doing this course. It's a hands-on course, 2-day course with real patients. And anybody who's interested in applying for that could contact on this number and on these details. And I wish all of you the very best, those of you who are taking this journey. It's a very fruitful, rewarding journey, and I strongly recommend it. But I just wish all of you the very best and say, go for it. Thank you so much. So, how do we proceed? FRC off? Okay, so while we are joined by our other speakers who are busy in another instruction course, we will move on to our next speaker, that is Dr. Rohan Sawant. Dr. Sawant has done his extensive training in India, as well as appeared for a lot of these examinations. In fact, he has recently cleared the FRC OFT as well, and he's currently working in the NHS in the UK, and we're very happy that he's been able to join us for this instruction course. He has a vast experience in all these examinations, but we are specifically, he's going to focus on the FRC OFT, and this is of special relevance for any of you who wish to emigrate, especially to the UK. Rohan, please, if you can.
Good morning, everybody. At the outset, I'd like to thank Devendra and Dr. Rashmin sir. Devendra mainly because he conducts this course and he is so much interested in giving back to the examinations or to people to share his experience. And I feel privileged that I can share my bit. And Rashmin sir especially because he is mentored through a lot of these examinations in the way and in the process to approach. So my talk today is my experience. So that's what I ended up doing. So a note about the Royal College of Ophthalmologists. As mentioned by Devendra in his slides, it was started in April 1988 as the voice of the profession in the UK. How does it help? It is considered as an exit level examination. It is a necessary qualification to be a consultant in the United Kingdom. Now recently it also provides PLAB exemption, which was not applicable when I gave the exam. That's why I ended up giving the Glasgow and the Edinburgh and the Royal College as well. And the latest update is this exam can now be exclusively given in India. You don't need to travel to UK to give any part of it. The exam format, as is with any general exam, 3 parts. Part 1, refraction, and Part 2, which is decoupled now into written and oral. So where can you sit the exam? Part 1 and Part 2 written are MCQ exams, which are now delivered online via remote proctoring, which means that you can sit in any country and there's no need to travel. The Part 2 oral and the refraction certificate now take place every year in India, Trinidad and Tobago, Egypt, Singapore and Malaysia. In fact, they are starting their first Part 2 oral exam later this year in Chennai, I believe, in November. A note about the Part 1 exam: you don't need previous experience in ophthalmology to sit for this exam, and this exam is based on the curriculum outcomes of the first 2 years of the ophthalmic specialty training, which is a run-through 7-year training in the UK. So you are expected to know the skills that are necessary to be a second-year resident in the UK. The exam is done 3 times a year. This might change because online proctor exams would be offered to many more candidates, and the maximum allowed is 6 attempts. It's a 2-hour multiple choice paper examination, 2 exams of 90 questions each, consisting of 1 best answer. So I'm just trying to, yeah. So you can give it at your home or your workplace. This exam is delivered over the internet to a computer, your own computer, at a pre-agreed date and time, and there is a 1-hour break in between 2 papers. This is just an example of the kind of difficulty expected. Let's not go into details of that. Preparation, as you see, some of these pictures are quite similar to what Devendra shared in his files as well. So for basic sciences, for all 3 Royal Colleges, I can safely say that the preparation is quite common. There isn't, except the format of the examination, there isn't anything different that you need to prepare separately. Optics, again, Elkington, because again, Elkington was a British person. So refraction certificate, you don't need to pass Part 1 to give refraction certificate. You can give refraction certificate independently whether you pass Part 1 or not. So a lot of people gain a lot of clinical experience in refractions and give the refraction certificate first before attempting the Part 1 theory. Again, you don't need any previous experience in ophthalmology. 3 to 4 sittings per year, max 6 attempts, and there was a paper version of marking when I gave the exams. Nowadays, it's been replaced by an iPad, so the answers are marked electronically, and there are centers in UK and Egypt. It's an OSCE type exam with 10 stations and 5 rooms. From November 2022, the exam is going to be conducted in hybrid format, which means that post-COVID, they are now starting to get patients to see face-to-face by the candidates. So it will be a good combination of simulators and face-to-face patients. So the exam is conducted in 5 rooms with 2 patients each. That makes it 10 stations. So 2 rooms will still have the simulator, but 3 rooms will have patients face-to-face. And the simulator retinoscope is the Hind retinoscope with hidden trial lenses. This is the standardized OSCE format. So you can see that a lot of emphasis is based on retinoscopy. Part 2 fellowship. It is open to candidates after passing the Part 1 and a refraction certificate. It has a written and oral component, which again is considered a synoptic exit level examination. So it uses different techniques, which are beautifully spread over a period of 2 sessions. And they use complementary assessment methods to see how well you do. So you're expected to demonstrate a depth of knowledge and understanding expected of an independent consultant. So it's not only a test of your knowledge, it's also a test of your demeanor, how you approach a question, how your facial expression is, and how nervous you feel on your face or you show if you're a bit out of water. So all that is actually watched. In terms of the training is expected to pass the written and oral examination before they complete their training, which is 7 years. This has been decoupled recently, so you can give theory and oral of the FRC off separately, maximum 4 attempts each. With the written component, it's held twice a year. Again, it's a proctored exam. 2 MCQ papers, 90 MCQs each. You have to answer a single best response from 4 options, 2 hours each, 1 hour break, similar to the Part 1 proctored system. Again, it's curriculum based. This is a blueprint of what the spread of the questions that you are expected to encounter during the exam. As you can see, if you go down, you even have about 7 or 8 questions of basic sciences there, 3 questions on research. So it's a comprehensive test of ophthalmology and day-to-day practice in the NHS in the UK. Again, a couple of examples. Just putting this example in particular because you are expected to read recent studies and also know a bit about it, at least in terms of trying to give a pen notes of how things work with recent studies. So the way I approach them is I used to make 10 bullet points of each study, and most of the times it would help me answer these questions. Books slightly different, Oxford Handbook and Kansky, more importantly for the written and the clinical part. Kansky has got excellent pictures, there's no doubting that. That always helps to put a face to the description of the picture. Moorfields Manual, I personally used it a lot during the examinations. I always felt that that is a good practical source of how practice works in the UK. So it's very pinpoint, it is quite concise, and it gives you useful knowledge. There are also books that people have written who have passed previous exams, MCQs for Part 2 FRC Offs. This is, again, these are books written by trainees who have passed this examination. And they're also popular and a legendary CHUA website as well. There are other resources. I used Off the Questions, and they had an FRC Off module separately. And quite a lot of these questions were reflected in the actual exam. The Royal College has their own clinical guidelines and the service guidance. It's worthwhile going through them because you might get questions in the theory as well as in the oral exam. And NICE guidelines, because NICE guidelines are quite popular and followed in day-to-day practice. They have their driving and vehicle licensing agency, so you're expected to know the vision requirements for driving and the GMC Good Medical Practice guidelines. Coming to the oral examination, you are eligible after you pass the written. It is held twice in the year in UK and now once in Singapore, and recently they're going to soon start it in India. Again, max of 4 attempts. Once you pass the written, you can give Part 2 oral for your 4 attempts within 7 years. Structured Viva on Monday and Tuesday, and OSCEs on Wednesday to Friday. That's a standard format of examination. In Structured Viva, we have 5 stations. Each station has its own significance. Station 1 is patient investigation, so data interpretation. Devendra actually touched lightly upon in the Glasgow examination as well. They'll give you an OCT picture, for example, and ask you some questions, ask you what's the diagnosis, what do you think is the most common diagnosis, and a differential diagnosis. They'll give you a biometry and ask you to interpret it. Stations 2 and 3 are patient managements 1. So what they try to do is they try to cover all ocular emergencies, because you cannot get an ocular emergency patient to see face to face. So they try to gauge that knowledge on a Viva station. Station 4 is attitude, ethics and responsibilities. Station 5 is audit. Now Station 6 is the communication skills of OSCE, where you have an actor who will pretend that he's not happy with the way your colleague has treated him or her, and you'll have to basically talk the patient, the person out of try to address the concerns and try to escalate if it is worth escalating. So for stations 1 to 5, there is one examination, and station 6 has 2 examiners. One is a consultant ophthalmologist and another is a lay examiner. Station 6, now post-COVID, they are getting back to getting face-to-face patient contact. So all these last 2 years, they based this examination completely on videos. Now they are trying to marry both up. So there are 5 stations. The 6th station, that's the communication skills station, it's taken care of the Viva aspect of the examination. So now we have 3 patients per station. So in anterior segment, glaucoma, posterior segment and strabismus, we have 1 patient. but they still use 2 videos. So that actually, I think it's a blessing in disguise. So you still end up seeing 3 patients. Sometimes due to lack of time, in face-to-face, you might end up seeing only 2 patients. That doesn't change the marking of the examiner as such, but it just gives you a broader variety of getting different diagnosis through. Except neuro-ophthalmology, I just wanted to highlight this point to Rashmin sir. They still didn't manage to get videos of neuro-ophthalmology patients, so they still want 3 patients of neuro-ophthalmology to be seen. You will find these videos on the college website. Again, it's a hybrid format starting from November 2022, as I just discussed. It tests all your clinical skills, as mentioned. All this is mentioned in the college curriculum on the website. How to go about? Devendra already highlighted it. With Viva, you just have to be well versed with clinical scenarios in OSCE. Practice. The more you practice, especially subspecialty clinics, because as they consider this to be an exit level examination, you might get a lot of odd nystagmus cases as well, which you might not have seen. So it's useful watching a lot of videos if your center does not have access to patients specifically. Other resources such as college guidelines, the NICE guidelines, GMC documents, DVLA, strategic papers, all this is again a common lot which you can benefit by reading this for your theory as well as for your Viva and OSCE. As this is considered to be an exit level examination, I keep highlighting this during my talk, you are expected to demonstrate high level of knowledge and demeanor. You need to be at top of your game basically in terms of your knowledge and conduct, and as mentioned previously, they even mark you for facial expressions and your posture and the way you speak. Last important point, which I didn't manage to do during my anterior segment, and I got 1 mark cut off because I forgot to switch the slit lamp before I answered the question. Prepare early, score well. The best way is again to interact or consider each patient that you see as a clinic case or an exam case. To use your ophthalmic and medical care in day-to-day practice, get used to speaking that way, and that actually makes life very easy. And we had, my examination was almost more than 3 years back, but it didn't have a convocation, which post-COVID, we had it now. So I'm happy to answer any questions if you guys want to get in touch. I'm happy to share my knowledge. Thank you.
Thanks, Rohan. I know you've gone through the entire gamut, so it's always nice to hear your views, and I'm sure it'll benefit anybody who's going for these exams. It's my pleasure to introduce Dr. Meenakshi. She's our next speaker, and she is well known in ophthalmic education circles in India and internationally, and it's really a pleasure and a privilege to have been her student. She's recently stepped down as Director of Academics at Shankar Nethralaya. So her topic is on selecting your fellowship, and she'll be restricting herself to the Indian fellowships and what one should be looking out for in the fellowship that one is applying for.
Good morning, and thank you, Dr. Devendra. He was one of our star students, so it's an honor to be a part of his instruction course. So I'm going to talk a little bit about how do you go about selecting a fellowship. How many here in the, first let me thank the audience for being here with us on a Sunday morning, that too very early. How many of you here are looking at further training, fellowships, in the audience? Can I have a show of hands? Okay, great, thank you. I hope this will help guide you. So I'm going to start off with a little story. So many years ago, there was a young man from a small town in Karnataka. Arrived by train, that is the Chennai Central Station, and joined Shankar Nethralaya for post-DO DNB. After interview, those days there was an interview. But he had his dreams. He said, you know what, I'm going to finish I'm going to go back to my small town in Karnataka. I'm going to establish a hospital. I'm going to take care of patients who cannot afford. And we were very impressed in the interview that this young man has such lofty ideas of taking care and giving back to the community. What did he do after DNB? He did a vitreoretinal fellowship. Wonderful. Then he joined even as a vitreoretinal consultant. But then, after about 7 or 8 years, he got a wonderful opportunity in the Middle East and went away. Now, you may wonder, is this success? I mean, success because he did really well and now he's got a really cushy job somewhere, earning well. Or he never made it to his dreams. He never went back home and did what we thought what we were training him for. So anyway, there are many ways to look at it. But let's come back to the topic. When is a good time to do a fellowship? Especially if you're a lady, you have just finished your residency, perhaps parents, or you yourself have decided to get married. When are you going to start a family? Who's going to take care of your kids? So many questions are there when you decide to study further. So what is the ideal time? Is it soon after PG? What is the advantage of doing it immediately after the PG? Because you can crack the MCQ or the interview because your knowledge is still fresh. There is no break in surgical training. You can, wherever you leave off in your PG, you continue in your fellowship. Your faculty still remember you, your teachers still remember you. They are likely to give you good references and, even pick up the phone and call and say, this person is known to me, very good, excellent candidate for your fellowship, etc. But there is no time for a personal life at all. In fact, our fellows, when they used to come back and say, I'm getting engaged, I'm having my wedding, there is honeymoon, first Diwali, first Karwa Chauth, whatever, no leave. We just cannot give leave. So that is the disadvantage of doing it right away, soon after PG, just sailing into the fellowship. What about if you take a break and work for a little bit, maybe even have your family, and then decide you want to do a fellowship? What are the advantages of that? Well, you all are aware there are many programs where your surgical training is far from adequate. And so this break may give you a chance to remedy that. You may be able to work in charitable hospitals, you may be able to do short-term fellowships to improve your surgical hands before you go to especially surgically intensive fellowships like vitreoretina or oculoplasty. So it may also help you decide what you like and what you don't like. You may, go as an observer. For example, you might have gone to a medical college where they don't do any oculoplasty except DCR. So, but you have a feeling you may like it. You may even be able to go as an observer to a larger institute and see if this is your cup of tea before deciding to apply. And, well, for us women, you may decide to have a family, have a couple of babies, why not? And then even earn some money. If you're going to be working for a few years, you improve your bank balance, and then because your fellowship stipend is going to go down again, and so this gives you a chance to remedy that as well. So that is about timing, when to do. How about where to do your fellowship? So what are our choices? It could be a small practice. Many fellowships are offered in small practices. Or it could be in a large institution. Pros and cons of each. So when you look at a small practice, you can often continue to keep in touch with comprehensive eye care. What I mean by that is if you go to a large institution, and if you, for example, are doing vitreoretina, you only will do vitreoretina. You will hardly seldom be able to do comprehensive fellowship, except one or two institutes where the models have changed recently. You may even be able to get more surgery in some smaller places, especially if you have a good rapport with the chief of the place. Like a big institute like Shankar Nethralaya, I know there are fellows crib about call duties. There is, eye donation call, there are ward calls, there is OT call. In a smaller practice, there is less likely to be that many number of calls. What about a large institution? The fun of a large institution is, for example, if you say vitreoretina in Shankar Nethralaya, I think there are some 16 consultants. So imagine the number of points of view. You will get something about, somebody is doing only retinoblastoma, somebody is specializing in diabetic vitreous surgery, somebody is specializing in ROP. So you will really get a wide spectrum, wide points of view when you train in a large institution. The patients also tend to be more complex. You will see a wide spectrum of patients, from the very simple to the referred patients because it's a tertiary care center. You also have the fun of multidisciplinary interactions. Your retina patient who has, say, a bad glaucoma, you'll be able to see how fantastically this is managed if you are in a large institute with many disciplines. And many of them have junior residents, so you will have a chance at seeing if education and teaching is for you. But there are more calls, for sure. Okay, so that is something to think about. We have covered when to do it, the fellowship, and where to do the fellowship. Now we move on to which subspecialty. Now, Dr. Milind Nayak from LVP, I think this is in his website, How to Choose Your Ophthalmology Subspecialty, and there is even a version 2.0, and it's more a humorous take. It talks about if you are socially awkward and don't like to see patients, then you should do community ophthalmology. I don't agree with any of this. Or it says if you love children, you do pediatric, and if you want to run away from them, you can do the rest of them. I don't think that is true, but a lot of it is humorous. It does give you some kind of roadmap or guidance, but I'll tell you a little bit more practical ways to decide which fellowship. Before you even go in to decide which fellowship, prepare to decide. What I mean by that is exactly what you're doing. Go to big conferences, go to many sessions, listen to the stalwarts, listen to paper presentations, go look at the posters and videos. Decide for yourself, are you getting a kick out of this specialty? Is this something that's making you smile? Okay, so do this before you even start deciding. Watch videos. There are so many surgical videos, free videos on YouTube, teaching videos, to see whether this is your cup of tea. You can also, like I said, go hang out in the clinics. Ask to be an observer in institutes, go spend a week in the OT, and now that COVID is hopefully pretty much gone, I think observerships should reopen, should be able to go and observe. Webinars. I think we've all been inundated with webinars during the COVID. So many webinars, recordings are available. Go look at the recordings. See if this is what you like. Don't do it because you don't know what it is. I've had people apply for pediatric ophthalm and squint fellowship because they never did any squint in the PG. I'm like, how do you know? You join and you hate it. You hate holding the prisms. What are you going to do? Run away, is it? So the way you solve that is to what I listed before, to see whether this is your thing. Next, sometimes you have to decide about your fellowship depending on where you want to practice. This is a small little place called Karur in the middle of Tamil Nadu, population of 10.6 lakhs. You may not do well if you're going to do aesthetics, So you want to practice in Karur, that's your hometown, please don't do an aesthetics fellowship. You may not have patience. Maybe you come from an ophthalmic family and you are the last person who has to do the vitreoretina to fill the rest of the specialties. Then somebody has made the decision for you, so don't even fight it, it's okay. What about finance and practice style? You like really big money, don't do pediatric ophthalm. You love comprehensive, do small fellowships. Don't waste time on doing long-term fellowships. Do little fellowships. You want to serve the needy, maybe refractive is not the way to go. And if you're passionate about giving vision to your patients, that is your thing, then maybe plasty, oncology, definitely only plasty may not be ideal. If you don't like children, it doesn't rule out peds. If you like doing charitable work or working in the community, comprehensive may be a better option. You don't mind long hours of surgery, then these are the choices. And if you can deal with morbidity and mortality, then oncology is good. And other fun things is you have work with support teams like oncologist, ENT. If you do cornea, you may need support of an eye bank. If you have family commitments, don't do anything that is exhaustive. Before the interview, work on your CV, make sure the spellings have all been checked. And if you're going to an institute, see who published what in that institute. Read up before you go. Read up recent advances, which are always asked in interviews, because you don't even know what's happening in your field of interest. Then, how do I know you're going to be a good fellow? That is my approach as a teacher. And make sure you're well-dressed and groomed, rested, and you go to the interview on time. And have a plan. Improve your surgical skills with short-term fellowships, as I already told you. Make sure you have answers for who is going to take care of your child, how will you deal with your spouse being in a different place, how will you deal with cultural adjustments. Be sure you have thought about all these things before you go in. So very quickly, once again, a little story. Why did I do pediatric ophthalmology? I did my residency in the University of Louisville, and then I developed cervical spondylitis. So my mentors told me, don't do anything very intensive surgically. So that ruled out vitreoretina, etc. And then I had to choose where to go for the fellowship. And I was offered Bascom Palmer, but that's in Miami with a lot of crime. And I was going to be I was offered in Chicago, again, a lot of crime. And I saw graffiti when I went for the fellowship interview, and it kind of scared me. I had 2 little kids at that time. So I chose University of Iowa City, a lovely college town. That's how Iowa looked when I went for the interview. But it was okay, it was only for a year. And so I did my fellowship from University of Iowa. So there may be other considerations how you decide where you want to do your fellowship. My little kids who are now grown and who are parenting me now. So I'm going to end with a verse. I believe it is the fashion to follow your passion, even if it leads you astray. Don't get on that ship called fellowship till you have thought your way. Family comes first, then quench your thirst for knowledge if you may. Advice I will give, love, laugh, and live. Be happy, end of the day. Thank you. Thanks, Devendra.
Lovely. Lovely. Thank you so much. Because we are running short of time, we'll rapidly follow that up with Dr. Akshay Nair, who's going to speak to us about the ICO examinations and fellowships, which are a very popular choice across the country. So over to you, Akshay.
Thank you. So I'll be speaking about ICO examinations and fellowships. So firstly, when we talk about the ICO exams, why do residents and fellows want to do the ICO examination? So at the end of the day, it's an assessment exam that tells you how good or bad you are. And it is a form of recognition amongst your peers and as well as your patients. In some cases, clearing an ICO exam may improve your chances of better job opportunities. And some of us, like Devendra, I know, take extreme joy in appearing for an examination. And also we love these 4-letter words after our names, additional degrees. So that's another reason to give the ICO examination. A big reason for why you should think of the ICO examination is that it has a reciprocity with the FRCS. In fact, they have really simplified it now, which means that if you have cleared your basic sciences, refraction, optics refraction, and clinical sciences or clinical ophthalmology, which is your either the clinical sciences or the advanced, you are exempt from any of the MCQ papers that they have for FRCS Glasgow. You directly can appear for the structured oral examination, which is very good because that's, in addition to saving a lot of effort and studying, also saves you a lot of money. What about the ICO fellowships? There are different ICO fellowships available. There are 3-month fellowships, there are 6-month fellowships, and there are 1-year fellowships. Now, if you look at the ICO website, it clearly tells you that it is recommended that you sit for the ICO examinations and clear them before actually applying for an ICO fellowship. Although, technically, it is possible to get a fellowship without having cleared the examinations. So, what are the pros and cons? You get an additional degree that you can write after your name. It could also get you better job opportunities if you're, the place where you're being employed is very keen that you have an ICO qualification. Also, it helps you in easing out the pathways for navigating FRCS that we send. But unlike, say, an MRC off or an FRC off, it does not allow you to practice in any additional country. ICO fellowships can be done even technically without having to appear for the examinations. At the end of the day, appearing for each of these papers is an expensive affair. So how do the exams pan out? The part A is called the Visual Sciences examination. It's an entry-level examination which is recommended that you take it during residency. It has 120 questions and MCQ option. These are just subjects that you see on screen are the ones that will be based on which questions will be asked. Your part B is optics and refraction, which has 60 questions again over 1.5 hours. Remember, part A and part B are always together, and you have to individually get passing marks in both to be able to progress to the basic sciences examination. In case you do not clear the optics and the refraction, then you have to take it separately and clear it to be able to give the next part, which is part C or clinical sciences. The best time to take this is just after residency. Right. So the best time to take it just after residency or during fellowship, because you've just cleared all your theory exams and your idea of your theoretical knowledge is extremely good. The next, they have introduced a new type of examination which is called the subspecialty examination. They have 7 different specialties, which is cornea, glaucoma, retina, plastics, neuro-ophthalmology, pediatrics, uveitis, and cataract is included is a part of each of these subspecialties. However, to be able to appear for this examination, you should have at least 1 year's clinical experience, which means you should be in practice for a year. The exam is a 2-hour-long exam with 80 questions in it. The examination fees can be extremely expensive. All examinations combined is almost 1.75 lakhs. So how do you prepare for the examinations? So these are the 4 recommended books. You've got Clinical Optics by Elkington, The Theory and Practice of Optics and Refraction by Khurana, John Ferris, which is the gold standard for MCQs for the ICO exam, and the Forrester for basic sciences. Also, the Massachusetts Eye and Ear Infirmary Review and Kansky. If you've read them cover to cover during your residency, rest assured during your basics and advanced examination, you will clear them. Sometimes for John Ferris, which is the MCQ book, questions are taken from the book verbatim without even changing the order of words or the orders of options in the MCQ book in your examination. So if you've really read that well and revised it a couple of times, you'd possibly find the questions easily. So we'll go to quickly fellowships, what are the different types of fellowships? You have 3-month fellowships, which can be in uveitis, ocular oncology, glaucoma, retina fellowships. You also have 1-year fellowships, which can be ocular oncology or retina fellowships. There are about 60 to 90 such 3-month fellowships awarded. It gives you a $6,000 scholarship, which can include your travel and your stay. The caveat is that you have to be under 40 years of age to be able to be eligible for this. It has a very transparent process on icoph.org. You select your fellowship, apply for eligibility. Once they check your documents and let you know that you're eligible, you can choose where you want to go. However, based on your application, if you're rejected, you cannot apply again, which is why you need to apply and make sure that your application is completely solid. What is a good time to do your fellowship? Ideally, after having done a fellowship in India, you should go for an ICO fellowship so that you can build on what you can write, on what you've learned. questions that are typically asked in your fellowship form is what will you do with the knowledge and skills that you acquire? What skills and knowledge do you wish to acquire when you go for your fellowship? You should write in such a way that you want to come back to your home country and serve such and put those skills that you learn there into practice. These are the kind of answers that actually help you in getting the examination. This was my experience. I was an ICO fellowship in oculoplastics and oncology 7 years ago at the New York Eye and Ear Infirmary. We were able to publish extensively during that time, and it was based on my ICO fellowship that I was inducted as a member of the American Society of Oculoplastics and Oncology. So to summarize, plan well, take all stakeholders, which means your family, your employers, and other friends whose advice you may actually be able to work on. Choose wisely so that you can build a career based on your ICO fellowship. Remember, it's not just a vacation. It can actually help building connections and improve the quality of your practice. At the end of the day, the ICO examination and the fellowship is definitely an asset. Thank you. If you have any questions, I'd be happy to take them after the session. And I'd like to invite Dr. Rashmin Gandhi to speak next.
Thank you. In the interest of time, I think we'll just conclude. We spoke about FRCS, we spoke about ICO, we spoke about FRC off, and what all we can do once you want to go and study in UK or work in UK. There are other avenues which are available now for a young ophthalmologist who is well qualified. There are lots of opportunities to do work independently because there are funding options available from high net worth individuals, banks and VCs. There are chains of eye hospitals who are now looking for JVs and who are looking for joint projects with people who are doing well. So apart from thinking about the training and the jobs, there is a good opportunity in today's environment to do something on your own. There are opportunities again in the healthcare technology sector where I know of a doctor who developed his own application, not an ophthalmologist but a physician, and now he has his company who has a valuation of around 150 crores. So there are these now because of the technology and advancement, there are the geography is no longer a limitation. As long as you have an idea which solves a problem, and as long as you have a tech support, you probably would be able to do a lot of these things. We probably would, half a minute, if there are any questions for any of the panelists, we'll take it. Otherwise, we'll hand over the hall to the next session. Yes, please.
Sir, FRC after the exit exam, it's eligible for practicing also.
Yeah, Rohan? Is FRC of the exam eligible for practicing in UK, you are saying?
Yes, sir. Which all countries
Yes.
it's valid?
Yes, absolutely. It's an exit level examination. With any fellowship exams, you can practice ophthalmology in the UK. But FRC lets you progress in your career quite quickly in the UK. I'd put it that way. You can still do whatever you can do, whatever your speciality is, regardless of whether you have Glasgow or Edinburgh or FRC off. But FRC off, as I put it in my slide, is one of the necessary qualifications if you want to be a consultant in the country.
So you must be knowing that FRC of now is being conducted in India. Yes. The one diet was conducted in Delhi and then next would be in Chennai.
Yes. So which all countries other than UK it's valid?
They are now conducting them in...
no, where it's valid.
Valid.
As a qualification, it's definitely valid in UK, Ireland. You can have a crossover qualification in Australia as well, and Singapore. In fact, Singapore residents are supposed to pass FRC off before they finish their residency as well.
Yeah, it keeps changing. You have to check with like Singapore, Hong Kong. Initially they recognized Edinburgh, then they recognized Glasgow. So you need to keep checking. It's a dynamic thing.
Thanks.
All right. I think we hand over the hall to the next session. Thank you so much. Thank you all the speakers and panelists.